Hello, Ms. Cooper. Hugh here. Gonna do my intramuscular injection skill checkoff video for you this afternoon. I've got my equipment assembled here, and to start, I would double check the order that I have on hand with the original order in the medical administration record, or the electronic medical record. That matches up. While we're in doing that, we're going to go ahead and check to see if the patient has any allergies to this medication, which he does not. From there, we'll just kind of review the order. It's for morphine, 10 milligrams, intramuscular route, Q4 hours, PRN for pain with a rating that's greater than 6. Again, he has no known allergies. I look in the record, and I can see that nobody has administered this medication yet. So our timing is right to go ahead and give it to him. Our indication is right too, because I've just assessed him, and I'm seeing that he has vital signs of 97.9 temperature, heart rate of 89 beats per minute, respirations of 18 respirations per minute. His O2 saturation is 97% on room air. His blood pressure is 144/86. And as I said earlier, his pain rating is 9 out of 10. Mr. Prime weighs 184 pounds. So I've assessed his level of consciousness. He is alert and oriented. He is just looking for some pain. Some of his vitals are near the higher end of the ranges, but because his pain is so bad, we would kind of expect that. So from there, I'll do a little bit of research on the medication that we're going to be giving him. We are only going to be administering medications to one patient at a time, and we're only giving Mr. Prime the one PRN medication. So indications for morphine are severe pain, and he clearly is having that with a rating of 9 out of 10. So it seems like that's an appropriate indication for him. The action of this medication is that it binds to opiate receptors in the central nervous system. It alters the perception and response to painful stimuli while producing generalized CNS depression. The therapeutic effects are that they decrease in severity. Pain decreases the severity of pain. In addition of naltrexone in Embeda product is designed to prevent abuse or misuse by altering the formula. We're not using that, so we will not really go into that. Some of the adverse reactions and side effects are confusion, sedation, dizziness, dysphoria, euphoria, floating feeling, hallucinations, headache, unusual dreams, blurred vision, diplopia, meiosis, hypotension, bradycardia, adrenal insufficiency, constipation, nausea, vomiting, urinary retention, flushing, itching, sweating, physical dependence, psychological dependence, and tolerance. Our high alert reaction is that it causes respiratory depression. So we're going to want to be looking out for that. So our route is intramuscular. So our dosage for an adult that's greater than 50 kilograms, which he is 4 to 10 milligrams Q to 3 to 4 hours. Again, that's for the usual starting dose for moderate to severe pain in an opioid-naive patient, which we're going to consider Mr. Prime for this exercise. So our dose is at the high end of the safe range, and our timing is correct. So some of our nursing actions, we're going to need to assess the type, location, and intensity of pain prior to, which we have done, and 1 hour following PO, subcutaneous, and intramuscular injections. It goes on to explain some information for intravenous, which we're not going to be doing. It does talk about using an equi-analgesic chart if we are going to change routes, or if we are going to be changing from one opioid to another. So one of the high alert nursing actions would be we're going to need to assess the level of consciousness, blood pressure, pulse, and respirations before and periodically during administration. If respiratory rate is less than 10 respirations per minute, we'll want to assess the level of sedation. Physical stimulation may be sufficient to prevent significant hypoventilation. Subsequent doses may be needed, may need to be decreased by 20 to 50%. Initial drowsiness will diminish with continued use. In addition, geriatric patients frequently are more sensitive to the effects of opioid analgesics and may experience side effects and respiratory complications more frequently. So Mr. Prine is an older patient. We're kind of at the higher end of the range. We're going to want to assess him. I'm going to decide to assess him every 15 minutes after administration, not in that 1 hour window that it says in the first part of the nursing implications. So we're going to check him a little bit more frequently, just to make sure that his respirations are good and that his level of consciousness is good. So prolonged use may lead to physical and psychological dependence and tolerance, but this should not keep us from using this to prevent his pain. Most patients who receive morphine do not develop psychological or physical dependence. Progressively higher doses may be required to relieve pain with long-term therapy. We're going to want to assess his bowel function routinely, institute prevention of constipation with increased intake of fluids, bulks, and laxatives to minimize the constipating effects. We're going to use stimulating lactives routinely if opioid use exceeds 2 to 3 days, unless contraindicated. We're going to assess for the risk of opioid addiction, abuse, or misuse prior to administration. For this exercise, we're going to say that we have done that and that he is not at risk. Abuse or misuse of extended release preparations by crushing, chewing, snorting, or injecting dissolved product will result in uncontrolled delivery of morphine and can result in overdose or death. Some of our lab considerations is that plasma amylase and lipase levels may increase. In the case of toxicity or overdose, we would use the opioid antagonist to reverse respiratory depression and coma. That would be naloxone. That's the antidote. It goes on to tell us what the route and dosage of that is. So that concludes our research. We're going to move on down to the Pyxis and go in and do our first and second checks and prepare the medication. So I'm going to go ahead, as I come into the room, I'm going to do hand hygiene and I'm going to get my PPE on. We're going to do our first check as we withdraw the medication from the Pyxis. So what we've gotten out is morphine sulfate injectable, 5 milligrams per milliliter. That's what we need. It matches up. We would scan that if we needed to follow the policies of the facility. And so we'll say that we have done that. And while we've withdrawn it, we're going to go ahead and check the expiration date on this medication, which for this exercise, we're going to say that it's not expired. And looking at the MAR, again, I see that this has not been administered since Mr. Prine has been here at the facility, which has been over 4 hours. So our timing is right to give this medication. We're going to go ahead and move on to preparing it. So we're going to assume that this has not been opened. We're going to take off the cap. We're going to get one of our alcohol wipes. We're going to scrub the hub for 10 to 15 seconds from inside to out to make sure that we're not contaminating our needle. So we have decided to go with a 22 gauge, 1 inch needle. Mr. Prine does not have a lot of adipose, so the 1 inch is going to be appropriate for him, and the 22 gauge is appropriate for an intramuscular injection. So we're going to go ahead and open that up and take it out. We're going to uncap it. We're going to take in an equivalent amount of air to our dose, so 2 milliliters, and we are going to inject that into the air above the medication. And then we're going to withdraw our medication. I can see that we've got a little air bubble in there, so we are going to withdraw a little bit more than the dose so we can get that air out of there. So we're going to get those bubbles to the top. We're going to get our dose back down to our exactly 2 milliliters, which we have. We're going to use our one-handed scoop technique to recap the needle. At the point that we're doing our preparation, again, we're going to do our second check and make sure that we have the right medication, which we do. So we've done our 2 checks. And we're going to make sure that the medication is always in our possession or always in our line of sight. We're going to go into the patient's room. We're going to go into the room. Actually, I'm going to take this PPE off. Do hand hygiene. Then we're going to go to the patient's room. Again, always having the medication in front of us. So when we enter the room, we're going to introduce ourselves. We're going to close the door and provide privacy. We're going to do hand hygiene. We're going to ask the patient to identify himself using his name and his date of birth. And then we're going to ask him if he has any allergies that he knows of to make sure that our medical record lines up with that. So at this point, I'm going to scan his ID bracelet if needed, scan the medications again if needed, and we're going to do our last check of the medications to make sure that it matches with our order and with the MAR, and it does. And so we're about ready to proceed to administer this medication. But before I do that, I'm going to make sure that I've got my 2 identifiers, I've done my 3 checks, which I have, and then we're going to go through the 9 rights of medical administration to make sure that we haven't skipped any steps. So do we have the right time? Yes, it's Q 4 hours PRN. It's not been previously administered, so that we're good there. Do we have the right route? Intramuscular? Yes, that's what we have the equipment for, and that's what is on the order. Do we have the right patient? Yes. We have, or do we have the right indication? Yes. 9 out of 10 level of pain. The order calls for greater than 6, so our indication is right. Do we have the right patient? Yes, we've used our 2 identifiers. We have scanned him in. Do we have the right preparation? Yes, we have withdrawn 2 milliliters to get, which is of 5 milligrams per milliliter solution to get our 10 milligrams of morphine that we need to administer. So we've got our right preparation. We have checked our expiration date. We're going to do some education with Mr. Prine about the effects of this medication and what he can do to help himself along through this process and understand the process. We have the right drug. We have the right dose, and then after this is all done, we're going to do our documentation. But having done our 9 right check, I feel good that we can move on with administering these drugs. So again, I'm going to do hand hygiene. I'm going to don my gloves. And because we're injecting 2 milliliters, I'm going to choose not to go with the deltoid and go with a larger muscle, the vastus lateralis. So we're going to help Mr. Prine onto his side. We're just going to expose the lateral aspect of his thigh. I'm going to use the landmarks of the greater trochanter and the patella. I'm going to go halfway in between those on the lateral aspect of the thigh. That's going to be our vastus lateralis. So once we've got it in position, we've got his leg exposed. We are going to clean the injection site. Circular motion, inside to out, 10 to 15 seconds. So after we have done that, we're going to let that air dry. So while it's air drying, we are going to get out our gauze pad for later, and we're going to uncap our syringe. And we're going to grab our syringe and our index, and between our index and our thumb of our dominant hand. Okay, we've air dried, and so we're going to take our non-dominant hand and we're going to pull the skin taut in a darting motion, 90 degrees to the skin. We're going to insert the needle, going to stabilize it with our non-dominant hand. We're going to slowly inject the medication, keeping the skin taut the whole time. We're going to remove the needle in the same direction that we put it in, and then we're going to release the tension. We're going to apply very gentle pressure with the gauze on the site. We're not going to recap our needle. We're going to put it in the corpse container. We're going to check he's not bleeding, so we don't need a Band-Aid. We're going to assist Mr. Prine back into a comfortable position. I'm going to take off my PPE, perform hand hygiene. I'm going to document, and then I'm going to follow up with him every 15 minutes for the first hour to make sure that his respirations are not dropping off, that his level of consciousness is good, and then after the hour we'll reassess his pain and see where he is at. We're going to provide some education for Mr. Prine about the medications, and we're going to also assess him long term for any kind of issues with bladder or bowel movements. So I'm going to go and dispose of this medication with another nurse witnessing me per my institution policy, and I'm done.